coming to you from beautiful Whitwell, Tennessee, which is on the Tennessee River, and it's not quite as cold as it is up in New England. But those of us in the South are shivering today. So first, I want to thank you all. As Anne has said and other speakers have said, I want to thank you all for everything you do for your patients every time. This is certainly a challenging time for all healthcare professionals, especially those of us who support and facilitate transitions of care for the patients, the families, the caregivers that we serve. So again, thank you. These are the objectives. I have no conflicts of interest. What we're really going to talk about today, and we're going to try and do something I haven't done before, so please bear with me. We're going to try and marry transitions of care with ethical concepts. Cindy gave you a great presentation about capacity and decision making. Those are things that are really important to transitions of care. So we're going to try that. We're going to talk about transition of care standards. I don't know if you realize that those are out there, but how do these standards impact our practice? But before I move on, I sort of want to give a disclaimer with these objectives. What I'm presenting to you this morning is not a map or a directive or a recipe for providing professional practice of case management. It is rather an attempt to foster a greater awareness of the standards and the policies that guide our practices. Each of us is accountable and responsible for implementing these statements of professional practice as they apply to our unique disciplines, certifications, and roles as a case manager. So I want to tell you, we're all in the transition of care business, but we're not in this business alone. And sometimes I find case managers feel it's my job to facilitate the transition of care. I've got to put all the pieces of the puzzle together. But truly, we are members of a transdisciplinary team, and each member of that team has a responsibility in helping us to facilitate an appropriate transition of care from our patients. You know, healthcare as I knew it, as a young nurse, which was a long, long time ago, I look pretty good, but I have been a nurse for many, many years. And since I started in nursing, healthcare has changed dramatically. We really respond to mandates that are focused on balancing quality and quantity. In the past, we looked at the quantity of services and we build on the quantity of services. But now we are really being judged on not the quantity of care that we provide, but the quality of care and the safety of our patients and achieving outcomes. Those are all things that we're evaluated on. And those legacy models of care for coordination are really fading to be replaced by that more consistent focus on quality. We are charged, as you heard Cindy say, with facilitating good choices for our patients and avoiding harm. I like to go back and talk about this document. Now, this document was first introduced 20 years ago. So, and it was exciting 20 years ago when the Institute of Medicine, now the National Academy of Medicine, came forward and said in a document called Crossing the Quality Chasm. And if you haven't read this, I really ask you to look and read the preamble, if nothing else. And that preamble says the U.S. healthcare delivery system does not consistently provide high quality medical care to all patients. Americans should be able to count on receiving care that meets their needs and is based on the best scientific knowledge. Yet there's strong evidence that this is not always the case. Healthcare harms patients too frequently and routinely fails to deliver health potential benefits. Indeed, between the healthcare that we now have, and remember this is in 2001, in the healthcare we now have and the healthcare that we could have lies not a gap, but a quality chasm. When the Affordable Care Act was passed, there were lots of provisions that looked at advancing the quality of care. And we are touched now by a lot of those provisions. Another thing that it put forward was the National Quality Strategy, which really focused on using incentives to improve quality of care, tying those payments to quality as provided by healthcare professionals. And we have lots of metrics out there now that define what is quality of care. And those metrics are always changing. But the National Quality Strategy always has three primary goals: better health for our patients, better care, and lower costs. Better health for populations, better care for individuals, and lower costs to the systems. They really promote better teamwork, better coordination of care across healthcare settings, more attention to population health, and putting the power of healthcare information to work. We are still struggling with this. I'm going to tell you some stories about my life, my patient's life, the community where I do some pro bono case management. I am finding that as we look at healthcare information technologies, our patients are confused. Recently, I had a healthcare challenge. And one of the interesting things I found is that I have count them, 4 patient portals. How many of our patients can navigate 4 unique patient portals? If we are going to engage and empower our patients, we have to make sure they have all the tools that are available to them, including those access to patients' portals, and understand how to use those portals. And that's sort of my personal focus right now, is how do we engage our patients and let them know, how do we educate folks? And I'm from the South, so you'll notice that I use the word folks. And if I say things like y'all, please don't criticize me or feel that I'm from the South. Originally, I'm from Chicago, so I'll have a blended Chicago Southern accent, which is sort of unique. So back to the presentation, quality strategy goals. The National Quality Strategy put forward these goals: reducing harm to our patients, making those better choices, reducing harm, improving support for a culture of safety. Now, as we heard Cindy say, patients can make a decision to go into environments that are unsafe. But if a patient is moving into an environment, we as case managers, as members of the healthcare team, and the whole team needs to be involved, need to look at, is this a safe environment? If it isn't, how do we mitigate that? How do we support them to be safer? Reduce inappropriate, unnecessary care. Does the patient need all these services right now? Or is there an ability to reduce unnecessary care? Or do we throw everything out at them just to say we did it? Prevent or minimize harm in all settings. Help patients and their families to be engaged and empowered in the patient care. Facilitate communication and coordination of care. I'm going to talk a lot about communication. Promote prevention and treatment of chronic disease. Does the patient know what it means to have diabetes, to have heart failure? Do we explain it in terms they understand, and working with communities to help people live healthier lives? Might be easier in an urban setting. I live in a very rural setting where healthcare services aren't always available. And if they are, you have to drive multiple miles. So what's healthy for somebody that lives next door to a hospital or near in the vicinity of an acute care facility, and how is it different for somebody in a rural environment? Why is this important to you? Well, this is some information that comes to us from AHRQ. And I think this is very interesting. Nearly 20% of patients have an adverse event within 3 weeks of discharge. And these could be, more than half could be prevented. Adverse drug events are the most common post-discharge complications, with 1 in 10 discharges have errors in medication information. Hospital-acquired infections and procedural complications cause considerable morbidity. Insufficient care coordination. This is something that we can work on. Is there going to be a smooth handover to the patient? You know, we talk about handoffs. I don't like that word. It's almost like this patient is your problem now. What we want to do is a handover. I'm giving you information so that this patient can be successful. As many as 20% of patients are readmitted within 30 days, and poor transitions cost Medicare as much as $26 billion with a B each year. And this graph, and I sort of have to give you a heads up maybe, I made some modifications to my slide, sorry Maureen, last night and this morning. So there may be a couple of slides that you all don't have, but I will forward the updated deck to Maureen so she can share it with y'all. And one of the things I didn't mention on the intro slide is my email, casemanager@mac.com. Please feel free to email me to ask questions, to get resources, even to say, Nancy, I don't agree with you. It's okay. This is a graph, and this is from an article written by Stephen Jenks and Eric Coleman a long time ago, published 13 years ago. And it talks about re-hospitalization. Now, I don't want you to think that I'm saying case managers are responsible to prevent discharge. Some of our hospitals may tell us that. All we can do as a case manager is follow the standards, follow the codes of professional conduct, to look at our job descriptions. We cannot guarantee that patients will be successful, but we can facilitate that smooth handover of the patient to the next level of care, to the next healthcare professionals. But look at this. 13 years ago, they said that patients were readmitted. 20%, almost 20% of patients were readmitted within 30 days of discharge. And I have some statistics here, and I want to pull them up so that I'm not speaking inappropriately to you. So I pulled these from Medicare Compare, Healthcare Compare. And if you haven't gone to that website, Medicare Care Compare, and I can share that URL with you, anybody that wants it. What that does, it has the patient assessment of healthcare providers and systems data on there. And there's 3 specific questions that are asked of patients that I think really impact this process of transitions of care. The first one is, did somebody explain to you the medication before you received it? And I think this is really important. How can we expect patients to follow a medication regime when they go home if we don't tell them what meds they're on in the hospital? And patients are saying only 63% of patients say, yes, somebody told me what it was. In your 5 states, that range of answers goes from 60% to 69%, so a little bit better than the national average. The other question is patients who reported, yes, I was given information about what I need to do when I go home from the hospital. And this is a great number, 87% to 89% of folks in your 5 states say yes, with a national average of 86%. But here's the rub. The next question, patients who strongly agree that they understood their care when they left the hospital. The national average is 52%, and in New England, it ranges from 52 to 56%. So we're telling patients, these are the things you should do, but they're not understanding what we're telling them. This is one of our biggest challenges in transition of care. We move so quickly now. We have to move those beds because we have patients coming in with COVID, but even before COVID, we moved quickly. We needed to have heads in the beds. We needed to get them up, move them out rawhide. And this is something that I say, and I know it may be a little irreverent, and I apologize for that. But when I was a child, there was a TV program on called Rawhide, and Clint Eastwood was in it when he was young and good looking. And it had a theme song that went something like this: get them up, move them out, rawhide, drive them in, drive them out. This is what we have done in healthcare for years. And we always haven't given patients all the tools they need to be successful. The patients haven't understood those tools, or we move so quickly that when the patient got home, they said, what do I do? Colleen Morley, who is the incoming president of CMSA, has done some research on transitions of care. And one of the patients she talks about is a patient that was given that stack of information when they went home from the hospital. And it was information overload. And what did the patient do with that information that also included all his scripts for medication he needed as he was moving, addressing his illness, trying to manage his disease state? What did he do with it? He took it home, put it on the table, and put a plant on top of it so the papers could absorb any water that leaked from the plant and didn't touch the table. So we give patients so much, but do they understand it? Do they understand the value of it? We have patient education failures, including that patient's readiness to learn. We tell them what they need to do, but maybe they're not ready to hear it. And there is some readmission acceptance. It's interesting. Every time you call a physician's office right now, you get the disclaimer that says, if you're having a problem, call 911. And people do call 911. Maybe not so much now in COVID because they're a little leery of EDs, but they may call 911. And where do they go? They go back to the hospital, and they may be readmitted. So these are some of the causes of ineffective transitions of care. Premature discharge. This is a word I want to mention to you because I want you to Google it. Because if you Google the term premature discharge, you're not going to get definitions of it. You're going to get a list of 20 attorneys or 30 attorneys that are really looking at that transition of care as a source for legal intervention. So premature discharge, are we getting them up, moving them out too quick? Does the transitional care plan address the patient's culture or health literacy? Do they understand the discharge instructions? Have we spoken to them in a language, not always English or Spanish or another language, but in a manner that they'll understand? And kind of social factors, including geographic areas, you know, what you can do in your large urban areas, you cannot do when I live, and some gaps in post-acute services. Now we're going to talk about transitions of care. This graphic I loved because it really represents a handoff. We're just moving the pieces along. Back in the day, we would give patients a packet of information as they moved from acute to post-acute care. And often we would give them the look that says, this information is not for you. You give it to the nurse when you get to the facility. We need to go through that information if we are going to, in fact, do a handover rather than a handoff, so that the patient knows what to expect at the next level of care. These are the definitions of transitions of care that come to us from both CMS.gov and the National Transition of Care Coalition, and their web address is ntoc.org. Transitions of care is the movement of the patient from one setting of care to another. It can also be a transition from one focus of care to another. So if you have a patient who is diagnosed with cancer and there has been a curative focus of care, maybe they move from that curative focus to a more palliative focus. Also, I'm including this definition. This comes to us from Vivian Campagna, who is with the Commission for Case Management Certification, Case Manager Certification, talking about transdisciplinary teams. Transdisciplinary teams are a team that transcend disciplinary boundaries, fostering a sharing of knowledge, skills, and decision-making with a focus on real-world problems and the inclusion of multiple stakeholders, including patients, their families, their communities. It is just not the role of the case manager. We may be the most integral member of the transdisciplinary team when we are working with patients to facilitate that smooth handover to the next level of care. And I probably should stop right here and say, you know, the next level of care isn't necessarily a facility. It can be a home. It can be a child's home. It can be a community setting, an assisted living facility. Wherever is the transition, we need to ensure that there is that smooth handover of information to the next level of care. And handovers really include putting all those pieces together. This is, as I said to you earlier, I had a health issue earlier at the end of last year that required me to go to the outpatient every day for a number of weeks. And this is a sign. You can see that it probably says Merry Christmas there, so it was Christmas time. Do you see anything wrong with this sign? It says transition of care. Do you only get one? Is this all you're entitled to? Is one transition of care? No, it's transitions of care. They are a process. They are not an event or a destination. Care coordination, putting all those pieces together, really focuses on putting everything together. And it's only one aspect of the transitional care process. It's not just putting those pieces together, but making sure that everybody understands. And we need to know that the role of the case manager is most closely associated with the standards and codes of conduct. So we're going to go through definitions, and then I'm going to stop and take some questions if there are any, or I'll just move forward. These are the two definitions of case management that come to us from the Commission for Case Management Certification and the Case Management Society of America. I have to tell you, these are the longest run-on sentences that really don't define what you do as a case manager, what we do as case manager. They bring forward the functions of case management and the goals of case management, promoting quality and cost-effective interventions and outcomes. But I have some news for you, and hopefully I won't get in trouble with CMSA, but what are they going to do to me? We are coming forward in the new standards of practice that are being revised and should be out to the membership sometime this spring. We are including a patient definition of case management. Has not been completely adopted yet, so I can't tell you what it includes, but the idea is that we can explain to patients what we do in a manner that is understandable, that really defines what we do as case managers. And even though, if you've seen one case manager, you've seen one case manager. And I say that based on my experience with the profession of case managers. Not all case managers fulfill the same roles, functions, job descriptions. We have case managers whose primary focus is utilization management. We have case managers that are focused on transitions of care. We have case managers that do workman's compensation. I really believe that the one key that brings us all together, the one topic that brings us all together, is transitions of care. Because even in population health, we are looking at that patient's movement through the healthcare continuum, through healthcare services, maybe only going home from the PCP, but really understanding, what do I do next to maximize my ability to achieve the highest level of wellness that I can achieve? This is the philosophy of case management that comes to us from CCMC, looking at what we do as case managers, facilitating client wellness and autonomy through advocacy, assessment, planning, communication, education, resource management, and service facilitation. It's based on the unique needs and values of a specific client. We ensure that care provided is safe, effective, patient-centered, timely, efficient, and equitable. And those words, safe, timely, efficient, equitable, patient-centered, and efficient, all come to us from crossing the quality chasm that I talked to you earlier. The philosophy of case management also says we enhance the services we provide to the patient by looking at patient privacy, confidentiality, health, and safety through advocacy and all the legal and ethical considerations that Cindy talked about later, and we'll sort of blend them in. The Code of Professional Conduct says that board certified case managers recognize that their actions or inactions can aid or hinder patients in achieving their objectives. If you have achieved CCM certification, this Code of Professional Conduct applies to you. It also says that board certified case managers accept responsibility for their behavior, and that we provide a variety of services, and we are obligated to do so in a manner that is consistent with our education, skills, moral character, and within the boundaries of our competence and experience. I've already mentioned this, but I wanted to put it forward one more time. Case management is a means for improving. Is a means, not the only means, but it is a means for improving client health, wellness, and autonomy through advocacy, communication, education, and identification of service resources and service facilitation. guided by the ethical principles of autonomy, beneficence, non-malfeasance, justice, and fidelity. Before we move on to the transition of care standards, does anybody have any questions or comments? I know I'm giving you a lot of information very quickly. Well, I don't hear any, so I'm going to move on. These standards, these transition of care standards, you may not be familiar with them, but they come to us from the American Case Management Association. I know that is another association, but if you are a case manager, you need to be aware what professional organizations that impact the practice of case management are saying. ACMA put these standards together by bringing together a group of 15 representatives of different case management practices. And these consensus standards came forward from those multiple meetings. And and you can download these, you can review these at transitions with an S of care.org. Number one, our role as a case manager is to identify patients who are at risk for poor transitions. Now, we can do this with different tools that are out there. Many acute care facilities use LACE tools that look at length of stay, acuity, comorbid conditions, and frequency of ED visits. But there's other tools out there. What validated tools do you use in your practice? Are there some that you would like to share with the community of case management? Because the first thing we need to do is assess patients. Many acute care facilities provide case management to everyone. But is there a specific patient that we need to give just that little bit more focus as we assist them to be successful in their transition of care? We have to screen for medical, behavioral, and social factors associated with the high risk for poor transition, including social determinants of health. And we all have to have a social determinants of the health slide. Certainly, Ellen would not be happy with me if I didn't talk about social determinants of health. It is interesting that as we look at patient populations, only about 20% of social determinants of health are focused on access to healthcare services or healthcare environments. The greatest amount of social determinants of health, 40% of them look at education. Where do you work? What's your family support? What's your income? And how safe is your community? If we do not look at social determinants of health, we may not help assist our patients to be successful as they move through the healthcare continuum. Physical environment is only usually 10%, but if you live in rural America, it may be higher. Or if you live in a disadvantaged community, it may be higher. And then 30% are some of our health behaviors, diet and exercise, and ability to adhere to the treatment plan. I want you to think for a minute. How do these factors contribute to the patient's readmission risk? I'll tell you a story. I was working with a facility, and one of their biggest challenges was recidivism in the ED. Patients that saw the ED as a source of primary care. But they also had this one patient who came to them multiple times a week. And she would display all the signs and symptoms of an acute coronary event. And she would be evaluated, and they would decide that no, it wasn't an event, that she could be discharged back to her home environment. And over a 6-month period, and of course I have to tell you, she was uninsured. So over a 6-month period, the costs associated with her care were in the hundreds of thousands of dollars. And they tried to identify why she kept coming to the ED. And, you know, her explanations were, I'm in pain, and she knew all the stories to give them. And then she developed a rapport with one of the social workers who worked in the ED. And it was identified that she came to the ED because she was scared to be home and alone at night, because she lived in a changing community where safety was a concern. And after her husband died, she knew that she could go to the ED because it would be safe there. So what did this hospital do? They made her the night volunteer in the ED, and she made coffee and did other things. She was safe. She no longer came there as a patient, but she came there as a volunteer. What are some of the creative things we can do to help our patients? You've heard about advocacy, and Cindy did a great job of explaining beneficence and non-malfeasance. But as we identify our patients, are we identify all those patients that would benefit from our case management services? The Code of Professional Conduct says case managers may be called upon to provide a variety of services, and they are obligated to do so in a manner that is consistent with their education, skills, moral character, and within the boundary of their competence. After we have identified the patient who may be appropriate for transitional care interventions, we need to do a comprehensive assessment. And this is hard. This is difficult because often patients aren't, I was going to say the word honest, but that's not a bad word, aren't completely truthful in setting forward the challenges they have. They don't want to bother us, or they don't want to tell us what their true circumstances are. So sometimes we have to be, as Cindy said, those detectives, figure out what's really going on with the patient. What are their self-care ability? What is their capacity versus competency? And what is their willingness to be an active partner in the transitional care plan? Assessment. This is from CCMC, and this is their definition of assessment. Not only relying on what's in a document, and I think COVID has made assessment much harder. As I work with some facilities, the assessment process has now become virtual or done by phone, so that we reduce exposure of healthcare professionals to any kind of infection that might be prevalent in an area. So are we assessing via phone? And is that more difficult? And do we need to have a HIPAA compliant Zoom system that will really allow us to see the patient, to look at their face as they're giving us information, so that we can get a sense of what's truly going on with this patient in this situation? Other ethical considerations are keeping our commitment and our promises to the patient. If you can't do it, don't tell the patient you're going to do it. Compassion and truthfulness goes with fidelity. And CMS says we need to reevaluate the patient's condition on an ongoing basis to verify any changing needs, and to incorporate those needs into the transitional care plan to ensure post-acute hospitalization is to ensure that the possibility of readmission is mitigated. I love this cartoon. It says, this is worse than guilty. The jury found me non-compliant. How often have we maybe not focused on a patient because of a history of non-compliance or non-adherence, which is such a much better word. Really listening to the patient to hear what their barriers are. Is it getting the medication? Is it having access to food? Is it understanding their diagnoses? A number of years ago, Pfizer developed 3 questions that patients should be asked, and I still think they're valid today. Number 1, ask the patient, what's wrong with you, patient? Can you tell me? Can you tell me what your diagnosis is? How many patients have no idea what diabetes is? In fact, in the South where I live now, nobody has diabetes. They all have a touch of the sugars, so they don't think that it's a concern. So what's your diagnosis? Number 2, what do you need to do about it? Patient, can you tell me what you need to do? And maybe this is part of teach back that we'll talk about later. And why is this important? What's wrong with me? What do I need to do about it? Why is this important? What might happen if I don't follow the plan? The next standard, after identification and assessment, med rec. And often this falls to case managers, and I'm starting to see a trend within acute care facilities where there's a pharmacist who is meeting with the patient and going over with that patient their medications. Rather than giving the patient the list of all the medications that they received in the hospital, and this still happens. I just saw some the other day. Patient got a whole list of medications, even though she wasn't receiving those medications as part of the discharge plan. It wasn't accurate. They, of course, were PRN medications. And we also have to look at what else is the patient taking. Not only the prescribed medications, but patient, what's your medication regime when you go home? In the South here, we have the little gentleman that makes something up in the mountain and it comes in a screw top jar, a little bit of the remedy that maybe they shouldn't be taking with certain medications. Also, we now have, you heard it said in my intro that I'm a member of the American Cannabis Nurses Association. Well, I live in a saintly state that doesn't have adult use or medical marijuana. And really, we don't like to use the word marijuana. We say medical cannabis, but most of the state laws are written medical marijuana. Do we ask the patient, are you using any plant-based medicine like cannabis? Because cannabis can interact with many prescribed medications. But if we don't ask and they don't tell, that patient may fail when they go home. And that's part of the assessment process and also part of the medication reconciliation process. We need to respect the patient's right to self-determination, but we also need to tell them what might occur if they take certain steps in their treatment plan, if they quit taking their medication, or they only take a half a pill a day rather than a whole pill because they can't afford the cost of their medications. Asking the patient, are there any barriers to you successfully taking your medications is a strong component of transitional care standards. So we've identified, we've assessed, we've done med rec, then we need to establish a dynamic case management plan that addresses all settings through the continuum of care. Even if they're just going home and they're going to see the PCP in a week, we as case managers need to assure that the patient knows what's their role in that week. What do they need to do when they go home? Because I've already told you that patients are saying as the surveys go out, that they didn't understand what they needed to do. Communication and sharing of the care plan. And there's a couple of us who've been involved with CMSA, most notably Jose Alejandro, who has been a past president, who was a president and now past president of CMSA. Jose and I both hate fax machines. Don't ask me why we use fax machines. It's something that's easy, but they go into a black hole often. I think that more and more we have to develop as a healthcare industry, electronic pathways for information to go from one sender to a receiver, because in every transition of care, there's a sender and receiver, whether it's the case manager in the hospital to the case manager in the post-acute environment, the transdisciplinary team in the hospital to the community team. There's a transition of care, and we need to make sure that there is that smooth handover of information as they go through the continuum. Some of the ethical considerations when we develop that dynamic care management plan include what Cindy talked about, self-determination regarding what's the best interest. Patients, as Cindy said, make bad decisions, but it is their right. They have the autonomy to make those bad decisions. And we have to make sure there's an ability for each person, family, caregiver, to be engaged in partners in their care. Patients are not something that people that we do things to. We partner with them as case managers to facilitate that movement. And it takes a whole interdisciplinary team. And I know we're moving so quickly now, and it's so difficult to do this, but I would like to see every time that a healthcare professional interacts with that patient, that they talk not only about their current care, but where's their destination for transition of care. And then we need to communicate essential care transition information to all the key stakeholders across the transition of care, the continuum of care. And it should include all of these things: diagnosis, comorbidities, medications. What is their history of adherence to those medication? Labs. How many times are patients transitioned with lab results pending? And that information, when it does come available, doesn't always go to the next site of care. Maybe it'll show up in the patient portal. Maybe it won't. Any kind of cognitive impairment. Patient that Cindy just talked about had some cognitive impairment. Do we always realize that our patients are cognitively or functionally impaired in the brief time that we spend with them because we are moving so quickly? Some of the challenges with communication is the ability to talk to the patient in a language that they understand, that the families, that the caregivers understand. And sometimes we have some very abrupt transitions. A bed came available. It's time for you to go. All of the things that we say to patients that may not really represent an efficient and effective transition of care. And do we have a fiduciary responsibility to put the interests of our patients first, our employer first? Where is our fiduciary responsibility? Well, if we look at the Code of Professional Conduct as presented by CCMC, our fiduciary responsibility is to put our patients first and to communicate any barriers to members of the team that says this is why this patient with these circumstances may not be successful in their transition of care. I'm going to look at this and then we're going to stop for a minute. This is a survey and it's a little bit old, but I think it really represents what some seniors say, and many of our patients are seniors. And I say this as I am also wise and seasoned, which is my way of saying I'm old. Okay, survey done by Caremore, 1,000 seniors. 85% of them said I have something wrong with me. 64% said they saw more than 3 docs in a year. 3. And that's probably now that number would be higher. Almost 70% said they rely on their families to coordinate their care. 60% who were hospitalized said no one coordinated their care in the first 3 months following discharge. One of the things that I have to stop and say here is that I talked recently to a patient who had 6 case managers. 6 case managers. She had one at the hospital. She had one in a post-acute environment. She had one from her ACO. She had one in the community because she was in a PACE program. And she said to me, these are marvelous people. They have been so helpful to me, but they don't talk to each other. So I am the only source of continuity among all of them. I know it can be difficult to talk to managed care case managers. I won't tell you my story, but I'll talk to you offline sometime to tell you my story. But anyway, it can be difficult to find managed care case managers. As I listened this morning to some of your sponsors, your provider partners, they talked about having a case manager. We really have to utilize all the case managers in the community and managed care organizations at facilities to come together for us to come together to say, how can we each help this patient to be more successful? We have more commonalities than we have differences, and bringing us together to advance the patient's goals is very important. And finally, from this survey, less than half of those surveyed reported that they were asked about treatments or medications prescribed by other doctors, highlighting possible risks to patient safety and good outcomes. So stop here. Anybody has any comments or questions?
Nancy, there is one comment, and that is crucial point to discuss alternatives with individuals from diverse communities.
Thank you for that comment, whoever made it. Absolutely. One of the things that I have been involved with is PCORI, which is the Patient-Centered Outcomes Research Institute. They are grant givers. And I am asked to be involved with healthcare disparities. And as we look at healthcare disparities throughout our communities, even if you lived in the most wealthy community in any area of the United States, there would be healthcare disparities. Maybe a lack of knowledge about what to do, when to do it, and why to do it. So let's talk about transitions once more. They include, it's all these pieces, like the picture, pieces of the puzzle that have to be put together. But I don't, in any sense, want anyone who's listening to this to think you're the one who is in charge of the puzzle. We all have our contributions. It's like putting the pieces out on the table, and different people come by and try and put the pieces together. Sometimes our role might be the coordination of getting those puzzle pieces put together, but we are not responsible or accountable for the final picture that gets together. It's all of us. And because of that, we have to clearly define everybody's role and make sure that all members of the transitional care team are fulfilling their responsibilities in a timely manner. these are just some of the essential aspects of care transition: patient and family education and engagement. What's their well-being? You know, we send patients home, especially patients who are, I hate to use the word elderly, but in their 80s, and there's a husband and wife, and they're both frail, and there's an expectation that they can put everything together when they may not have the knowledge, skills, and ability to do so. We have to manage complex discharges. What does that patient have to do, and are they capable of doing it? There needs to be a continuity of care, that handover to whoever is going to be responsible for that, the care of that patient in the next level of care. Each one of us is accountable and responsible for facilitating the patient's successful transition to the next level of care, to the next encounter with a healthcare professional, to a level in which the patient is capable of managing their own care. This is not survival of the fittest. This is facilitating the patient's movement so they can be as successful as they possibly can in the next level of care. And the heart of every transition of care is collaboration. Collaborating with members of the team, collaborating with the next level of care, or the next level of care after that. Very often we focus on where they're going next, but where are they going after that? Because we have to start thinking about their whole healthcare journey as they are leaving the scope of our care. And part of our problem is we have silos. Silos that restrict the flow of information and truly compromise our ability to advance that safe, timely, efficient, effective, equitable patient journey. Communication. What we have here is a failure to communicate. It requires a sender and a receiver. If someone is not receiving the information that we are sending, it is a communication gap, and ineffective pathways are one of the primary barriers that successful transitions of care do not occur. We have to have that smooth handover of patient-focused information. And you need to be a street smart case manager. What do I mean by that? When we talk about the legal and ethical considerations for case management, we need to realize that ineffective communication may compromise that patient's ability to be successful in the next level of care. We need to talk to each other rather than faxing each other. We need to talk to each other rather than letting the patient be the conduit for the communication, because often patients are not accurate in sharing that information because they didn't understand it. You know, we're all pieces of a puzzle. And I'm just asking you to be the piece that you are so that you're doing a part in completing that picture for the patient. We need to develop real-time relationships and informal linkages and strong bonds of trust. That's why through the years, I have always relied on my partners in care. Folks like you, the sponsors that you heard speak today, whether they are providers or they are sources of information or advocacy for your patients. Who's out there that can be part of our team that helps that patient be successful? And what role do you play? And maybe I talked too much about the pieces. Maybe I should be talking about putting the pieces together. What is your transitional care's Parse partner's motivation, especially from the family? Is it social, financial? When we're talking about healthcare providers, is it patient safety, outcomes, recognition? Am I going to maximize my ability as a provider to help this patient achieve the highest level of health that they can achieve? Can they achieve the outcome? Can I report that outcome? Professionalism is being fully accountable. Too often we don't get out of the machine and move the log so that we can make the line straight. We just go around it. I've seen this too often, not so much in case management practices, but healthcare. We need to be fully accountable for meeting the standards, meeting the principles that apply to our practice, our unique practice of case management. I want you to read this. I know this is much easier to do in an on-site presentation, but what does it say? Many of you are saying it says Paris in the spring. What it says is Paris in the spring. Sometimes we whip through things so quickly because we have to, because we got to move on to the next thing. But sometimes when you get that feeling, and we've all had those feeling, we've walked into rooms, we've talked to patients and their family, and we said, this is a disaster waiting to happen. Sometimes we just have to stop and take a deep breath. We have to huddle with the team to say, there's a problem with Mrs. Smith and the transitional plan that's been developed, and maybe we have to tweak it a little bit to better meet her needs, because I've talked to the patient, I've talked to the family, and I have this feeling. There's a lot of transitional care models out there. And I'm not saying one is better than the other. I'm just saying that there's models out there. And if you'd like to see some of the models, one of the ones I recommend is caretransitions.org. Dr. Eric Coleman out of the University of Colorado at Denver. He has a marvelous transition of care program that really focuses not only on the patient, but the caregivers. Project Red, Brian Jack from Your World, from Boston University, put together Project Red, which is re-engineering discharge. This has been around for a while, and it included computer systems where patients would learn about their continuing care plan. Project Boost, that comes from the Society of Hospital Medicine, that has a screening tool for transitions of care, that evaluates patients' risk after discharge, that has the 8 Ps that look at problems with medications and psychological and principal diagnosis and physical limitations, and poor health literacy. I mentioned health literacy, but it is amazing to me as I talk to you about diabetes and it being a touch of the sugars in the South. Different ethnic groups, different racial groups use different terms for healthcare functions. Are we using terms that they understand? Are we only using terms that we understand? Patient support, prior hospitalization, and palliative care. Those are the 8 Ps from Project Boost. And the transitional care model. This is Mary Nadler's model, where they have an advanced practice nurse go out to the home and work with the patient to truly identify, is that patient engaged as a partner in their care? Is there any safety challenges? Do we need to look at increasing patient satisfaction with the process? If the patient is unhappy with the process, if they're angry about the process, will they be successful as they transition? And the goal of all of these is to reduce readmissions and emergency department use. Excellence in case management and transitional care is measured in quality, not quantity, in the performance of duties, not the completion of tasks, and in facilitation of desired outcomes, not the delivery of instructions. I'm going to tell you this story and then I'll take some questions. I know you represent acute care, but this is a story of a patient in the community, but because of his challenges, he was a frequent flyer at the local hospital. This gentleman, and this is a story that was in the Chattanooga Times Free Press, and I live in Chattanooga. This gentleman had a neurodegenerative disease. It was a genetic disease. He was a brilliant man, but his mind was functional and his body wasn't. So he lived in a project, lack of a good term, but he lived in an apartment building that was designed for low-income people. And if he had a challenge when he was in his apartment, he would pick up the phone and call 911. In fact, in 1 month, he called 911 90 times, 3 times a day. He dropped his remote. He couldn't get to his phone. He couldn't get in his wheelchair. His home health aide didn't show up. Lots and lots of challenges. So the fire department, and while they embraced helping this gentleman, they realized it was not sustainable. So they found a community case manager who started to work with him. He was on Medicaid and Medicare, so he's dual eligible. They got him in a PACE program. And he got in a PACE program that addressed the fact that he was malnourished, that he had lost whatever function he had previously had because of muscle wasting. So they got him into the PACE program. He went every day. The PACE bus came and picked him up. They made sure that the caregiver had been there and got him dressed and ready for the day. They got him appropriate dietary consult. He had been on a puree diet that he couldn't tolerate because it tasted so blandly. So they worked with a speech therapist to help with his swallowing difficulties. They got PT. And the end of the story is that 6 months later, he called the fire department once for assistance, and he wasn't readmitted to the hospital within that 6-month period of time. It takes the community all working together if we are going to be successful in transitions of care. We have, before I go on to this, we have a couple more questions.
Yes, Nancy, there's a comment thanking you for reviewing the Ask Me 3 important questions to teach patients and families to ask. And then there's a question, will any of the case management organizations generate a recommended CM to patient ratio for different levels of acuity to allow directors of case management to advocate for staffing levels to work at this level of practice?
This is an ask. This is an ask that I think CMSA is partially looking at, but I think it could be enhanced. And so I'm going to ask that one of you copy that question and send it to me so I can forward on. I have a call a little bit later this morning with some of the past presidents of CMSA. CMSA is putting together a caseload calculator. I have not seen it. This is a new modification of the old caseload calculator. Not sure it is available yet, but I will find out, and I will send a message back to you when I find out. And that's a tool. And that's all it can be. As I said at the beginning, case management, each of our roles is unique. And it's very difficult to come up with one size fits all. But with the caseload calculator, it takes into consideration your unique practice of case management. So let me find out more information about that.
And then there's just an additional comment from the person that wrote that question. Decrease in length of stay tends to be the maker of CM success for a CFO.
All right, not quite sure I understand that comment. And if there can be clarification, that would be great.
And another comment, please try to assess levels for rehab, often long-term planning care management, not just inpatient generally. So I don't know if we need more definition from that.
I understand. That's why I said each of us has a unique practice of case management. And I'm going to challenge everybody that's on this call. You know, we have some amazing publications here in case management. I want to encourage you to write about what you do. And maybe if that's too difficult for you right now, here's another option. The Chicago chapter of CMSA has published 3 books as of now. They're working on the 4th one that tells case management stories. I encourage you to tell your story. Nobody knows what case management is. Well, let me suck that back. The typical patient, the typical person in the community does not know what case management does. My husband, for years, has told people I'm a nurse who deals with insurance. This is not something I want on my tombstone. So people don't know what case managers are. So maybe once we get this consumer definition, that will expand. But write your story, submit it to Chicago. I'm sure that your chapter leaders can facilitate the pathway for your stories to get to the Chicago chapter. Or maybe you in Boston and New England, me, suck that back. You in New England can write your own story. Or your own book that tells what case managers do. And we do that by telling stories. My proudest story hasn't anything to do with how quickly I got the patient to the next level of care. It has to do with the outcomes that I helped the patient achieve, that I made a difference for someone, whether it was helping them get to a place where they could have the end of life that they deserved and desired, or maybe it was I helped them towards wellness by being a member of that team that helped them move forward. But those were my successes. It had nothing to do with length of stay or saving money for a healthcare plan. So we need to tell our stories. If you know, you can do it at your church, you can do it in your community, but tell your stories. I told you that I had a health issue in December, and I called my insurance company, which is a Medicare Advantage plan, because you all know I'm wise and seasoned. And I had to talk to 6 people before I got to a case manager. And when I got there, she told me I wasn't sick enough to be part of the case management program. This is not case management. This is not what we do. So share your stories. Couple more comments?
Yes, there's an additional comment which states, sorry, it's hard to read. I agree with you. Nobody knows what case managers do. If you are a case manager, do you know and understand? Even healthcare professionals don't know. So I guess that's a general feeling.
And we as a professional organization, and I can say this as a two-time past president, we can do a better job of helping you in identifying what a role is. You know, we did a PSA a couple of years ago when I was president, a long time ago when I was president. It's still on the CMSA website that talks about, I am a case manager. How many of you ever stopped to look at that public service announcement? And I've never seen it anywhere other than the CMSA website. Maybe your acute care facilities can develop a blib that they share with patients about what is a case manager and what will the case manager do. Of course, the legal department may not like that, but those are some of the things we can consider. I'm going to move on and I'll stop later, but I want to tell you the rest of the story. This is where I live. On the left side of the screen, I live on the Tennessee River. It doesn't look like that now. It's pretty gray and cold, but I live on the banks of the Tennessee River. And every June, we have the turtles that come up out of these are mud turtles and snapping turtles that come up out of the river. And they come and I live on a steep hill. And they come and they walk up the driveway and they go across the road and they lay their eggs and they come back. And one day, I live on this little tiny narrow road. It's not even 2 lanes. It is paved, but it's not 2 lanes. It's like a lane and 3/4. And there was a little boy on the road waving his hands, telling me to stop. And I noticed it was my neighbor's son, Dylan. And I said, "What's going on, Dylan?" And he said, "There's a turtle crossing the road." I said, "Dylan, there's hundreds of turtles that cross the road every day." He said, "Yeah, I know, but I'm out here and I'm going to save every one of them that I see today." Sometimes we have to realize that we can't save everybody, but maybe there's one person out there that we can make a difference for. And I love this quote from Dr. Seuss. "To the world, you might be one person, but to one person, you might be the world." And to one person, I can guarantee that those of you out there that work in acute care, that you have made a difference for not just one person, but for many people because of your commitment to advance quality and appropriateness of care through the healthcare continuum. Finally, our role is constantly evolving. And I ask you to send messages to the leadership of CMSA and say, "I need this from you. In order to be even more successful, I need this from you. How are you going to get it to me?" Talk to the leadership of your chapter. Tell them what you need to be successful and say, "I need this from CMSA." I need you also to talk to your leadership and tell them, "These are my challenges and these are my successes." And accept the fact that you are not Superman, you are not Superman woman, you cannot leap tall buildings in a single bound. We can do what we can do as long as we function within the scope of our practices. And celebrate your success. Rather than talking to the team about the patients that failed, talk about, "Gee, we got Mrs. Brown home and she'd been previously readmitted 5 times and she's been home for 6 months and look at how great we did." And then this. Do we have any more comments or suggestions before I play this little video?
Just one comment thanking you and saying this was informative and inspirational.
Well, thank you. And now, I've shown this video before, but I love it. So please, I apologize if anyone is offended by it. So we have a guy jogging in the woods. And he swallows a fly. I don't know why he swallowed the fly. And like many people who go jogging afterwards, he's taking a shower. Oops, I'm sorry. I'm sorry, I blew that one. The message after the video was, there is always a way out. There is always a way. If you are greatly challenged by anything, there is always a way to chat with people, to talk to people, to really look at what's going on with your patient, what we can do to be successful and help that patient. I mean, there it is. There's always a way out, except it kept going. This is a video for a GPS system. There is always a way out. Talk to your colleagues to find what that way is. And here's just a few resources. If there's anything else I can do to help you be even more successful in your practice of case management, casemanager@mac.com. Happy to help. And I thank you deeply from the bottom of my heart for the difference you make for your patients every day. Thank you. Anything else?
Just more thanks, and thank you for that. Always a way out. That's inspirational. And I would like to add all of our thanks for your expertise, experience, and insight. As I said at the beginning, that's invaluable, and it's reassuring for us new case managers that may struggle a little bit. So thank you, from me at least.
You're more than welcome.